question for the day for the entire panel is, with the rapid rise of recreational vaping among non-smokers, how should our clinical screening and epidemiological tracking evolve to capture this new demographic?
Thank you, Doctor, for the question. Indeed, very relevant in the field, as people know under social history. When you take patients' smoking history, you also need to now ask about vaping and other substances. So from that, you will capture the data that will be needed for intervention, given the fact that if you find correlation or high index of suspicion that the diseases that the patient comes in with can be related to the smoking and or vaping. Particularly vaping, people need to be more vigilant and include that in the documentation. As to what Sulastri mentioned just now, there's still a huge underreporting of EVALI. And that needs to start from asking the question, do you vape? Yeah, people always ask about, do you smoke cigarettes? So now inclusion of the question as well. So with that, you can build more data and then later can do the data mining to get the association and also causality for reporting purposes. Thank you.
Right, maybe I can just add on. I think Prof. Anki also already covered how that we should address this. But just to add on, I think I want to share cases from our friends here. I have Dr. Suhaila, Prof. Juhasan. For example, I received cases that she shared with me where we have school children, right, came into the hospital with psychiatric symptoms. But they end up to sent to the psychiatric ward first, and then only after the patient stabilized, then only they know that patient actually exposed to vape. So we have to always ask, because symptoms now are not really related to nicotine toxicity, which is something that we can see. The toxicrome will be like just GI symptoms, and the worst will be seizure. But whoever patient, especially when it comes to the illicit drugs now, they usually came, even for the cases that we receive now in Wellness Center, most of the cases involving illicit cigarette, they have this aggressive behavior, hallucination, deliriums, I don't know, they have become very scareful for family members. Okay?
That was mixed with chemicals, right?
Yeah.
They will become zombie-like.
Yeah, I think that one we can actually see, especially in the US side as well. So actually over there, you guys say check through the recent videos and so on. Yeah, mainly because of the chemicals they actually uptake. Perhaps I add a little bit in terms of the biomarkers part. So perhaps this is another area that actually under study, even though there are a few. I think the RNA sequencing is everything. People are trying to search for the markers for, I think, the last 2 years. So perhaps there's another aspect, in this particular aspect, perhaps other way of the biomarkers to detect for the particular disease, which is I think currently that's the area that it lacks. I think if let's say you are the clinicians and when you're meeting the patient, you hope that you can straight away get the result, the quick test and everything, rapid test. But basically at the moment we don't have it yet. So perhaps from MOH and the researchers and also clinicians, perhaps that is a way that we can figure out this is a niche area. If let's say we can figure out, if let's say we're able to come up, patent, actually we contribute to the world as well. And I know a lot of great researchers and clinicians, they are having a very innovative idea, which is we did discuss on this biomarker part potentials as well, yeah, and link with the WHO. Yeah, thanks.
Okay. Thank you. Okay, so my next question is to Puan Sulastri actually. So from the National Poison Centre's perspective, are there any specific red flag symptoms that clinicians often overlook when it comes to a patient presenting with ENDS related symptoms?
Thank you. All right. I think I've just mentioned about the involving of illicit cigarettes, illicit substance. Now, because before this, whenever patient involved in vape poisoning cases, so we will only focus on the nicotine toxicity. But nowadays, with the substance abuse, so it is quite difficult actually to predict, because the substance also are very variables from and it change rapidly. We start detect with synthetic cannabinoid, and then comes the intermediate. Once we just start to search for intermediate, it comes fentanyl, and so just ban it lah.
It's not the comment, but it keeps us moving and keeps our job as well. Just a joke.
Is there anything to add on? Okay. Yeah, it's true. Okay, so moving to our next question that is specifically directed to Dr. Haniki. How do we reconcile the current clinical disease burden with the marketing narrative that these products are harm reduced?
Very controversial question, yeah? There's a split among the researchers, healthcare professionals regarding the use of e-cigarettes, particularly as a harm reduction tool for smoking cessation. Yes, if you look at Cochrane review, there's a live review on Cochrane stating that there's evidence supporting the effectiveness of e-cigarettes for combustible or conventional smoking cessation. And it makes sense, yeah? You're giving nicotine as rapid and as much through inhalation, just by substituting cigarettes with e-cigarettes or ends. So you can stop smoking cigarettes by vaping. It makes sense. Okay? The Prof has shown, Professor Sri has shown, you supply nicotine as much or more than cigarettes. So why do you need to smoke anymore? Yeah? Plus the narrative from the industry saying that it's less harmful, but we get gathering evidence that it's not. So if you look at the cessation point of view, yes, they have evidence, but if you look at the studies closely, then you'll find there are issues with the studies contributing the data. For example, the subjects or the participants of the studies which have shown to stop smoking by substituting vape, yeah, they quit smoking but they stayed vaping towards the duration of the study, as compared to, for example, subjects who were given NRT. They quit smoking, then after 3 months, they stopped NRT. You see the difference? They're no longer nicotine dependent. But for the vapers, for the smokers who quit smoking by vaping, they switch to vaping, they become vapers. And we also have data that some of these vapers, they then smoke again, they become dual users. So in the end, the narrative that smoking is vaping is a harm reduction approach is not entirely safe. Yeah, so it's more of smoking substitution. Yeah, so it substitutes one form of nicotine addiction through cigarette smoking with nicotine addiction from vaping. So we have not advocated this in Malaysia, but there are some of the researchers, healthcare professionals, particularly affiliated with the vape industry. Yeah, you can see their track record, whether in research or being sponsored in talks or vacation to European countries. They are affiliated with the industry. So they can choose and then scrutinize and believe those who do not have any vested interest when they talk about harm reduction. So I hope that's clear.
Maybe allow me to add on what just now I mentioned. Everything is safe until one day is proven unsafe. Maybe I give a very simple scenario. You know mercury, right? Thermometer, right? So years back, I think as science students during early generations, when they enter into chemistry lab, they can play around with the mercury in lab. It was deemed safe, right? Until today, one thermometer with mercury break, you need carbon bar, right? So the point is, back to safe or unsafe, chemically speaking, yeah, sorry, my background is a bit biochemistry, so we back to that. So it's a combination of different compositions. Yes, to a certain extent, certain chemicals are lesser compared to combustion secret, but on the same time, we got additional others which is we unknown, and some combinations of the known in the combustion actually higher inside the wave as well. It's an up and down of the mixture's diversity. The fact is, and you play with the voltage some more. So how we actually able to confirm is safe? You can say safe, yes, until one day is proven unsafe, but how long that particular person have been taken? Can we reverse the time? We can't. Alright, so safe until one day is proven unsafe. That is something that the understanding perhaps we need to keep in the mind as well. Alright, thanks.
I've got a question, sir. When should we, as clinicians, sort of have the suspicion that we should send for toxicology? This vape is, this vape substance is something, this patient is. When should we trigger, or we should send this for toxicology?
Okay, so I'll just repeat the question.
Is it like sort of like bizarre clinical presentation, like you said, psychosis and things like that. So should that trigger, is there anything like sort of like red flags? When should we trigger you ask for toxicology?
I'll just repeat the question for the public to hear. So the question is, when as clinicians should we trigger suspicion for toxicology of a certain vape compound? Basically, what are the red flag symptoms for us to trigger a toxicology report notification?
Okay, thank you for the question. I think this is good for everyone, especially for all health practitioners here who ever met patients. So one good news is, under KKM, there are actually guidelines for notifications. As you see that my presentation just now, I've informed that there are notification for EVALI, but in this year, they start to expand the notification for cases for non-EVALI as well. So meaning that if once you have a patient that you have a history of vaping and you see the patient having symptoms, that will actually explain and the criteria of what kind of cases that you can notify, and then you can send the samples. This is a process where not only for the government practitioners, also for private practitioners, whenever they face any cases involving vaping, so they can actually report to the PKD. Then from the PKD side, they will do the investigation. What most important is to ask your patient to keep the samples. So I think I believe that this year they will establish that new guideline. Before this, they're only focusing on EVALI, but since we see the trend is not just EVALI, and we miss a lot of cases, non-EVALI cases, so there have been an effort on that. Okay.
So the number that you quoted just now, as in cases for EVALI, is exactly the same as the notified cases? Is that right?
Yeah, that is actually from the KKM, the one that notified to direct to the KKM. The one that I've shown you from Poison Center is different, but might be the same case that we received and patient developed EVALI, but I'm not sure sure about that. But there are possibilities that cases that refer to us for poison center. Also the same case that were reported to MOH patient who have EVALI. Because in poison center, we receive the first intake call whenever patient arrive to the hospital, usually from ED. So for that cases, we cannot get a diagnosis EVALI yet, right? And whenever they call us, we always advise them to report through that notification as well.
It's the same notification that's within the 24 hours? Is that
Yeah.
that's the same system? Okay. So that's done online. Now it's done online.
Now it's online, right?
Yeah, it's done because I was in ED for 18 years. So it's actually done online now via e-notification within 24 hours based on suspected cases.
Right.
So it's not totally concomitant.
Yes, it's either probable or
Assalamualaikum warahmatullahi wabarakatuh. Actually, it's about maybe also but may I know about how about Shisha?
kurang pendengaran.
Okay. Assalamualaikum.
Yang tu Pak Duduk.
come forward and take the mic.
Assalamualaikum. As you know, there is studies about vaping and also nicotine. How about Shisha? Shisha is part of recreational activity. Is it concerning the activity? Is it harmful to our health?
Very much the question is about the harmfulness of shisha. Thank you for the question. The simple answer is that all tobacco products are harmful. This is also a statement from the WHO. So anything that's not supposed to be taken other than clean air is harmful when you inhale, isn't it? Well, some farts are smelling bad, so it may be harmful, but that's a different story. But we're talking about intentionally inhaling tobacco smoke and 7,000 chemicals plus 70 carcinogens. So definitely it's harmful because it's a form of burning of tobacco as well, and the whole myth about cleaning or purifying it through water is nonsense. Yeah, it doesn't work. So, but fortunately it's not so rampant or so frequent among general Malaysians, so it's more of the lower prevalence in terms of use. Having said that, it can be very dangerous because it exposes the user to a high content of particles, particularly tar, particularly carbon monoxide, because it's direct burning and it's macam probably if you inhale exhaust of a vehicle and you inhale that directly, imagine doing that, you burn anything organic in this form of tobacco leaves that put into foil and molasses and other chemicals and flavoring heated to charcoal. You get the smoke and you inhale through water, still smoke, plus water, vapor, whatever. So it can be equivalent to 1 hour of shisha session can be more, at least 200 sticks of cigarettes. That has been reported. So, short answer, they have both.
In terms of legal, shisha also is defined as a smoking product. So it is controlled under the Akta 852 lah, and so it's the same lah.
So with nicotine and traditional cigarettes, we give NRE. But now with vape and all these, I don't know how many hundreds of chemicals and all this, is there anything that is currently being developed to sort of help with the cessation, as in you know, medications or drug-wise? I mean, it's difficult to just use motivational interviewing, and you know,
Yes, I know.
it's so hard. It's so hard. So what can we offer?
Let me repeat the question for everybody to hear. So currently for smoking, we have nicotine replacement therapy in place, but the question on ground is that what are the therapies or are they being developed for vape products and other inhalation products?
Thank you. Very relevant question. Yes, currently in Malaysia, there's no medication approved for vaping cessation. In some countries, particularly in the UK and Australia, there are NRT products approved for this indication. So it's in the pipeline. So if they request and provide the pro forma and whatever regulatory documents, it may be indicated in the future. So for now, you have to go with the saliva.
But it's still nicotine based, right? So if it's
Yeah.
so what about like
Nicotine, you need nicotine to reduce the urge, the craving, and the withdrawal, to reduce. But the delivery system, the formulation is much different than that of tobacco products because it delivers nicotine in a controlled, lower concentration and lower speed, so there's no kick. Yeah, the whole point is that to reduce the urge, the craving. And then if they start to reduce their tobacco products, we can reduce their withdrawal symptoms. So the data on this is that it helps to increase success rate of quitting 2 to 3-fold. For example, if you know the patient is highly dependent on nicotine from vaping, from cigarettes, because you have tools to measure the level of nicotine dependence from various sources or nicotine delivery products. So if you give this medication, currently in Malaysia not indicated, so it's off-label. I treat my vapers with NRT, but I mentioned to them it's off-label. But it is logical because you're treating nicotine dependence and you want them to quit. You know it works with cigarettes, you know it works with vaping. So studies have also shown effectiveness of vaping cessation with varenicline and bupropion. So we don't have varenicline in Malaysia. We have bupropion, but it's a prescription item, and if your vapor is a depressed patient, it makes bupropion preferred choice. So these are all evidence-based, and it's all discussed in the 2025 clinical practice guidelines, which is available on the Academy Professor Malaysia website. If you don't find it, contact me.
it's off-label, right? What about adolescents? Adolescents,
Okay.
what can
The majority of the vapors that we see, another important question, what about treating adolescent vapor? Back to your saliva is the first choice. Yes, behavior is coupled with medication can increase cessation, smoking cessation. It also overlaps with vaping. You need medication and also behavior intervention. However, the medications are indicated for 18 years and above. For adolescent, it's a specialized case whereby you need the consent of the parent or the caretaker. However, this is where the conundrum starts. They don't want to reveal themselves as vapor or smoker or dual users to their parent. So in the end, we only have counseling. They usually don't have the same level of nicotine dependence as adults or chronic users. So they may be low to moderate level of nicotine dependence when you do the EFTND or the FTND. Or you can sort of biochemically verify with the carbon monoxide breath analyzer, or if you have extra money, get the cotinine strip. Because the CO doesn't work for vapor, exclusive vapor, you don't have combustion. You know this, right? You don't know. Okay, now you know. So you need to get the cotinine strip. Cotinine is the metabolite of nicotine, which has a longer half-life, about 10 to 20 hours. So you can detect 3 to 5 days prior use of nicotine product, including NRT. But usually they're not on NRT, they are taking nicotine from vape. So you can verify they have the certain level of nicotine, cotinine, in the system. to reflect their nicotine intake from vape. Because they also don't know, it's not labeled on the product. Yeah, on the product that they take, how much nicotine, and it's manipulated by the industry anyway. So what we ask them to do is to start reducing the number of sessions per day and number of puffs per session. Yeah? If they are 16, 17, I may start NRT off-label with consent. So far, I have not treated vapers below 17. Mostly university students, so they can be on NRT, so no problem. But if you do have below 18, yeah, don't underestimate the power of your saliva. It's powerful, yeah, because medication is given for a certain duration. Behavior intervention is for life.
Unfortunately, I've come across fathers who give their son, brothers who give their younger brothers, uncles. It's just.
Yeah, the first case of Bali is from an uncle who gave the plate to the nephew who's studying for SPM. Yeah, but that's a whole different story. That's why you need to have the behavior component in it as well, so that they are aware this is not the right way to boost your memory, improve concentration. Yes, nicotine will stimulate the release of neurotransmitters that will provide all those quote-unquote good effects, but it's short-lived, and then in turn it will set in withdrawals. So they need to understand this. How do they understand this? You have to explain. Have you used COVID testing? You spit into the vessel and then say.
What is it? Is it expensive? Because we sometimes do screening.
About 30 to 35 ringgit per strip. It may be cheaper now because they are generic from Taiwan or China.
So,
Or Prof can provide you the Sunway version.
And also the ankle was actually mentioned saliva, so prevent them to doing it. Because if let's say we think back what we talk about, the anatomy of it, I think governments are actually struggle, even the starting ingredient itself. Now, aerosol, right? So at this moment, I think the NRT, everything is like looking at the nicotine. Then how about the rest of the chemicals? Which one will cause addiction? Perhaps something that able to relate is like the gum sniffing, that kind of addiction. It's a different combination of chemicals in aerosols and everything as well. Now, we are just talking about using the nicotine particularly. For this way, there are so many. As a starting, we're also not sure already what are the aerosols and what they will get addicted. It is a long process. So prevention, perhaps, at the moment, is the only way. Yeah.
okay. Our last question for the panel is to Professor Dr. Gobeki specifically is, given the complexity of the chemical constituents in vape, what are the difference that you have seen in recent lab analysis that locally made vape has versus imported or outside the country made vapes have on the lung tissue?
I think this question is supposed to address to one stream. But anyhow, I highlight a little bit. I think the search is sitting behind there. Actually, in our university, we have some of the projects. Actually, we collected some vape liquid and we did some of the studies. I think she's presenting tomorrow on the aspects as well, a little bit. Then perhaps you will see we test on some of the lung cells and everything. But still, it's a small group initiative. It might not be really extensive and everything. Maybe I can pass to 1+3 as well and add on this aspect.
Actually, the study that has been done in Poison Center is not under me, but specifically is under Dr. Leong Lin Hui, who actually get the WHO grant to test samples from other countries. Surprisingly, when we get the samples, it's actually made from Malaysia. So it's actually Malaysian made samples. And the findings, you can actually go to our book. We can see that Malaysia is good in vape production, right? It give our country a good economy, so-called quote and quote. So yeah, we did testing on the aerosol actually, and we can see the difference in terms of chemical constituent comparing the liquid and the aerosols. Some degrade and has lower concentration, but the fact is we are worried most for the unknown chemical, just like what Prof. Gove mentioned. And unknown means we don't know, we cannot say that it is safe. And it is way longer that we have to wait until we can see the results. So basically, the chemical, I can't remember. I will promote you to go to our booth in the main hall. Alright, thank you.
Thank you. That comes to an end for our panel discussion today. It was a very fruitful session. Thank you to the professors and doctors here.